Hi everyone. A lot of pharmacists that I've talked to in Toronto have been seeing a surge of prescription forgeries. So I wanted to share the process that I teach my students on how to quickly identify likely forgeries, as well as how to make a quick therapeutic assessment for opioid prescriptions. As part of the video, we will go through a number of real-life forgeries, recent forgeries as well, and we will discuss the pharmacist's role within the opioid crisis. This video was recorded on April 2019. Just last month, in March of 2019, at least 22 people died of suspected opioid overdose in Toronto, which is where I'm based out of. So this is definitely a current and very important issue. This is not a new issue. Between January 2016 and September 2018, over 10,300 Canadians have died due to opioids. That's just over 2.5 years. 73% of these deaths are due to fentanyl, so these deaths are not exactly fueled by opioid prescriptions filled by pharmacists. In fact, Ontario pharmacists have tried to make an impact through the fentanyl Patch for Patch program that started in 2015. However, studies are now showing that this has had no impact on opioid hospitalizations or deaths. So I don't want pharmacists to feel guilty when they are dispensing an appropriate opioid prescription. But then what is our role as pharmacists? Well, we can actually still have a big impact. Part of that is through the assessment of opioid prescriptions. By detecting forgeries and reducing inappropriate opioid prescriptions, we can reduce the chance that these prescriptions can be a gateway to the street drugs that are causing overdoses. Dosing of opioids is also a very important issue and an opportunity for us to have a big impact. There are different levels of opioid overdosages. Of course, we want to prevent the respiratory depression or the other side effects that can happen with opioids, but if possible, we may also want to prevent euphoria as a side effect, since this can lead to abuse and dependency as well. Think about how you felt on the best day you've ever had, a successful first date, or maybe getting accepted into pharmacy school, or buying your first house. That feeling of calmness, optimism, excitement, and confidence can be reproduced chemically. The catch is, once your body has developed tolerance, then not having opioids in your system is going to cause inversely terrible withdrawal symptoms. So our objective for today then is to discuss a quick method to assess opioid and benzodiazepine prescriptions. We are then going to apply this process on a variety of real prescriptions where the majority of them are going to be forgeries. All of these scenarios are occurring in the real-life situation where the pharmacy is closing soon, the doctor's office is already closed, and it's an unfamiliar patient. So we want this process to work in the worst-case scenario. After that, we will discuss some tricks and tips to communicate and resolve these difficult situations. So a bit about myself. I have over 8 years of community pharmacy experience, and I'm a University of Toronto Preceptor of the Year recipient. So I have a lot of practical experience teaching students how to assess opioid prescriptions in practice. I recently stepped away from community to work on Medasys, which is an app that pharmacies provide to their patients to guide them through each dose of their treatments with reminders, advice, images, and videos. So it keeps your patients happy, adherent, and coming back to your pharmacy through mobile orders. Also, medications are added in seconds without the need to type a single character or make an account through picture taking. So if that sounds interesting to you, please check out our website. This presentation was originally done through the Toronto Pharmacy Club as well, so thanks to all the members who participated in that event. First, let's talk a bit about when are opioids indicated. There are studies that show that acetaminophen plus ibuprofen or naproxen can be as effective for a variety of indications outside of cancer pain with less adverse effects. This includes surgery, dental pain, or acute injuries. This doesn't mean that opioids are not indicated at all in these situations, but having a trial of acetaminophen plus an NSAID first at an optimized dose can be a great suggestion you can have for your patients. A lot of patients, especially opioid-naive patients, would be happy to trial an NSAID first if their pharmacist tells them it often works just as well without as many side effects. Benzodiazepines are also not recommended for chronic insomnia, so trialing non-pharm interventions with the addition of melatonin is a great suggestion for patients that have never had a benzo or Z drug before. Finally, when treating pain, make sure it is not neuropathic in nature. So how do we quickly assess opioids in the community setting? Well, I made an acronym to hopefully make it a little bit easier for you. First, we want to identify quickly if it is a high-risk prescription, which is a likely forgery. So we have criteria for that. Then we check the dosage. If it's an opioid naive patient or if it's a chronic opioid user, then that will change how we make that assessment. And after that, we check the supply. The quantity needs to be appropriate. So an acute condition should be treated for 7 days, and a chronic condition should be dispensed at a regular, predictable interval. Finally, we check the narcotic monitoring system for polypharmacy, and we can see if the prescription is early, which is not appropriate, or if it is filled late. If a fill is late, that could mean the dosage or quantity can be reduced. So if you have a good relationship with your local physician, they may be very happy to know this information. If a patient is not in withdrawal when they are picking up their high dose at a late refill, then it's likely either the patient is diverting or getting additional supply elsewhere. So this is the quick and easy criteria that we use at our site to identify likely forgeries. It's a simple address check. If the patient does not live within a 10-minute walk, and if the prescriber does not work within a 10-minute walk of the pharmacy, then the prescription is likely a forgery and must be verified. The majority of narcotic prescriptions that you will receive from patients outside of your area and outside of the doctor's hours of operation are forgeries. This is because pharmacists are more familiar with prescriptions from doctors within your area. If you work enough at a site, you will learn all the tendencies of the physicians close by. If you haven't worked at your site enough, you can still easily pull the image of a prescription from the same prescriber for the same medication to make a comparison. People who make prescription forgeries know this, so they will travel outside of their area, even to the other side of the city, if they hear there is a pharmacy that is lenient with opioid and narcotic prescriptions. The criteria you use to identify high-risk prescriptions does not have to be the address check that I use at my site. You can come up with your own criteria or have a list of opioids and quantities that you have decided must be verified. For example, you can decide that all hydrocodone prescription syrup prescriptions over 100 ml need to be verified if you are finding that you are receiving a lot of forgeries for that medication. Whatever the criteria, it should be objective. Do not rely on looks to determine if a prescription is fake. The majority of prescriptions are printed now, so you'll be getting prescriptions that look perfect. The criteria needs to be objective so that you are not swayed by whatever story the patient has for the need for that medication as well. And the criteria should be easy and quick enough that it can be performed by all staff and in a short period of time. By training all your staff to be involved in the process, you are making an environment where the pressure is not always on the pharmacist to identify forgeries. The purpose of this check is to make it easy for you to identify which prescriptions should be verified. It doesn't necessarily indicate whether the prescription is a forgery or not. But as pharmacists, we are so used to being handed a prescription and filling it. Some of us fill hundreds of prescriptions per day. You need simple and objective criteria to anchor yourself through all the pressures the patient puts on you and all the environmental pressures as well. And if there's a prescription that passes all the other checks that we will do, and you feel is valid, but does not meet your high-risk criteria, and the patient claims they need the medication urgently, you can offer a partial fill until the next business day so that you can verify that prescription. If it's a forgery, most likely they will ask for the prescription back, or if they agree to the partial fill and it is a forgery, then a couple of pills won't really cause much harm anyways. Now we are going to check the dose and directions, and a lot of forgeries will fail this therapeutic check. For starting opioid therapy, the 2017 Canadian Opioid Prescribing Guidelines suggest that the morphine equivalent daily dose be limited to less than 50 milligrams per day. Also, it strongly recommends that starting doses be restricted to less than 90 morphine equivalent per day. Now, you actually shouldn't rely on these guidelines to make that therapeutic assessment because we should actually tailor the opioid dose to the individual patient. What I mean is that for most opioid-naive patients, a 50 milligram morphine equivalent daily dose is not really appropriate, since we actually should be using the lowest dosage form and lowest dose available. So these are 50 milligram morphine equivalent daily doses for common opioids. You can easily recognize these doses and be able to make a quick assessment just off of this chart. But these doses will cause adverse events and can easily lead to a hospital ER visit in many opioid-naive patients, especially if they are elderly. So these doses may be not high enough to cause an opioid overdose, but preventing that adverse event, preventing hospital visits or potential euphoria and dependency is also an achievable goal. So please recommend the lowest dosages that are possible, such as Statix 5 instead of 10, Tylenol 2s, morphine 1 milligram instead of 2 milligrams, and allow patients to titrate up as needed. If your patient is opioid naive, then they will usually be very accepting of these recommendations. For chronic opioid pain, the recommendation is to taper to 90 milligrams of morphine equivalent daily dose. This is not an easy conversation to have with a lot of patients, but the first step is to teach them that doses higher than 90 morphine equivalent daily does not mean better pain control due to eventual tolerance, but does cause increased side effects and dependency. Having these guidelines is very helpful when communicating with physicians, since previously there wasn't really a dose ceiling that we actively try to avoid with opioids. Now these guidelines allow you to put pressure on prescribers to keep doses in check. Here's an example of the notes that I write. I keep it very simple, and I don't usually find the need to explain the consequences of opioids to prescribers. Next, we have to look at the supply or duration of treatment. Acute treatment should have a duration of about 7 days or less, while chronic treatment should have a regular predictable interval of every 7, 14, 28, or 30 days. Anything else is really awkward and is just going to cause problems down the line. The quantity prescribed should be considered a therapeutic issue, since we want to prevent diversion or recreational use. Finally, we are going to do a narcotic monitoring systems check. This may be a little different in other provinces, but in Ontario, it is a vital component of opioid assessment nowadays. Patients should only have one opioid prescribed at a time. You also don't want to see opioids and benzos together. Now, you may get prescriptions for both on the same prescription from the same prescriber, and this is because that patient has been on both for quite a while, and the prescriber is essentially thinking harm reduction. But what you don't want to do is be that pharmacist that starts the patient on both. If they are currently using a benzo, you want to push them to titrate off of it before starting an opioid, and vice versa. Now, chronic pain treatment should also be only prescribed by one prescriber or clinic. And there's 3 different scenarios where you will get an NMS alert for multiple prescribers. First, you might receive a prescription for an acute treatment, and the patient previously had another acute treatment from a different prescriber. In this case, you want to make sure that the duration of therapy doesn't overlap, and if there is an overlap, you need to make sure that the new prescriber is aware of the previous prescription. Secondly, if you are filling an acute supply for a patient with an overlapping chronic supply, this is possible if the new prescriber again is aware of the current interval in the previous supply that the patient had. And this needs to be documented in writing, of course. This can occur, for example, when the patient has maybe lost their regular supply and they're getting some supply to hold them over until the next fill. But even in that case, any remaining part fills needs to be canceled, and the patient would need to see their regular physician for reassessment. Your responsibility in this case is to ensure that both prescribers are fully aware of the situation and that they both have opportunities to intervene, and that the patient is not receiving extra supply. Finally, there definitely should never be 2 ongoing chronic opioid therapies from 2 different prescribers. When you are calling other pharmacies as well to resolve these situations, you can ask the staff to put a note on their file to prevent future polypharmacy as well. Knowing who the prescriber is can also be extremely useful. Walk-in clinics and emergency departments should only give lower dosages and quantities of 7 days or less. Hospital discharges should be limited to a 30-day supply as well. Now we're going to go through a number of prescriptions, and in these scenarios, again, it is the weekend, it's late in the day, it's just before closing, the prescriber cannot be reached, it's an unfamiliar patient, and we're gonna have to decide if we should dispense this medication. Okay, so the first thing we're going to do is do that address check to identify if this is a high-risk prescription. And I'll just let you know that this physician does not work close to my pharmacy, nor does the patient live close to my pharmacy. So we already know that we're going to verify this prescription. The pressure is off, basically. Your mindset is completely different than any other prescription because it's basically failed our objective criteria. We are going to continue with the process, though, for the sake of this presentation, and look at the dose and directions, and we see that it's hydrocodone, 5 mils PO/PRN. So that's just a PRN dosing, so we can't really assess it that well. But we see that the quantity is 300 mils. Now, hydrocodone is always going to be an acute treatment, so this quantity is not appropriate. So that's another red flag. And finally, we do an NMS check, although nothing showed up. This is, of course, a fake prescription. Okay, so when we do the address check for this next one, we also see that the physician nor the patient is in the area, so we're going to verify. And all that pressure is basically off your shoulders, just from that one assessment. Next, we're going to look at the dose and directions. Now, it's oxycodone 5 milligrams and Tylenol at 1 tab every 4 hours, PRN, so that's very standard. The quantity, though, is 95. So 95 is not necessarily an appropriate quantity if it is a chronic condition, a chronic pain condition. In that case, you want to see that their last fill was at 28 or 30 days ago because of the quantity, right? And if it's an acute supply, then it's inappropriate because we want to use only about a 7-day treatment or less. So next, we're going to look at the NMS to find out what's been going on. So if we look at the NMS, we see that the patient got oxycodone 30 tablets 19 days ago. So that means that the dosage being prescribed now is wildly inappropriate at 3 times, greater than 3 times their previous dose. So that's something that needs to be fixed and verified. On top of that, we also see the patient got hydrocodone 250 ml 16 days ago. So that's another big red flag because we don't want to use 2 opioids at the same time, especially something like hydrocodone, where you're using it as a cough suppressant. Is not a vital indication. So there are alternatives that we don't have to expose, where we don't have to expose the patient to the risk of having 2 opioids concurrently. And of course, this prescription was a forgery. Okay, so for this prescription, again, we're going to do the address check, and we see that this is not a patient that lives close by. So we know, again, that this prescription needs to be verified. Now, we're going to look at the directions as well. 1 tablet BID PRN is a little bit low for oxycodone, but not unreasonable. Now, the supply of 60 tablets, though, I want to ask you, is that acute or chronic? And the answer is that's a chronic supply. And we want to see, in this case, 60 tablets given 30 days ago, 28 days ago, or perhaps 14 days ago for this dose, for this quantity to make any sense. But we see that there was no NMS warning. Therefore, that's a huge red flag. That is not an appropriate starting opioid dose as well. So that also that's another reason that this prescription needs to be verified. And of course, it is a forgery, this one. For this one, the patient and prescriber is not close. We also see 2 opioids concurrently on the same prescription from the same prescriber, and that's a big red flag that needs to be verified as well. For this prescription, the address check is going to fail as well. The directions are 1 and 2 BID for Endocet or oxycodone. The quantity of 120 suggests a chronic supply. So we want to see 120 given about 1 month ago. The NMS though shows that this was filled too early, therefore again, huge red flag, and this is a forgery in the end. So this prescription is looking like a hospital discharge prescription. The hospital is not the closest hospital to the pharmacy, and the patient does not live close to the pharmacy. So this is a red flag, and so we have to verify this prescription. Now it's going to be for Percocet 1 to 2 tablets, Q46H, which is standard, but the quantity of 90 tablets is not really appropriate because it's given out from an emergency room physician. So that's 2 red flags that we need to resolve before dispensing. And finally, we check the NMS. On the NMS, we see that the patient previously had methadose 20 milligrams 3 months ago. So even though there's no overlap in therapy, because it is methadose and this patient has had therefore a dependency issue with opioids, that's another flag that as an emergency room physician you would never in that case give an opioid, like especially in that supply, to this particular patient. In this prescription, again, the address check is going to fail. The prescription is for oxycodone 1 tablet Q46H PRN. Quantity of 120 suggests that this needs to be a chronic supply. And we see no NMS alert. So in that case, this is then an opioid naive patient where this dose and duration of treatment is not appropriate. And of course, this is a forgery as well. So in this case, the prescriber actually is close to the pharmacy, and the patient is as well. For the medication, it's Tylenol number 3, 1 and 2 tablets Q8H with a quantity of 10. So that's a reasonable acute course. Now finally, we have to check the NMS. If we pull up the NMS, we see that this patient actually got Tylenol 3 30 tablets 18 days ago. So that's 2 acute treatments, and with 30 tablets 18 days ago, there actually isn't an overlap. So this actually does make therapeutic sense. The physician might be tapering this patient off. We also, though, get another NMS warning for oxycodone CR 40 milligrams, 120 tablets 16 days ago. So in this case, there's no reason for the patient to be on Tylenol 3s. If they're getting oxycodone, CR, that's 2 different opioids. Even though one is acute and one is long-acting, you want to use the same opioid. So this is not appropriate to give out, and it's also from a different prescriber. So this has to be verified with the physician. So this one is actually a real prescription, as far as I recall. For this prescription, the patient actually lived close to the pharmacy. It's for alprazolam 0.5 milligrams, 1 tablet QID for 30 days. So that's a chronic quantity. We want to see the patient getting 0.5 milligrams QID 30 days ago as well. And what we actually see is that the previous dose was 0.25 milligrams. So what you can do in this case is you can ask the patient, did the doctor change any of your medications? As a check, instead of asking, did the doctor increase your medications? But for this particular case, it is such a high dose increase that you have to verify either way. And when we did, the physician was able to get that fixed. So for this prescription, the patient and the prescriber are not in the area. The medication is for zopiclone 7.5 milligrams PO QHS PRN for 30 tablets. So that's not a starting dose of zopiclone, and it's not a starting supply of zopiclone. Now, unfortunately, with zopiclone, we're not able to rely on NMS to see the patient's previous history, But we're still able to verify with the prescriber, and we were able to do that, and this prescription was given out. Now, in this particular case, the patient did come back on a later date with a fake prescription. In this case, they have Ativan, midazolam, and zopiclone at a much higher dosage. So very easy to identify that this is a forgery, but I think this is an example of a case where you don't want to let your guard down, even after verifying one of their previous prescriptions. For this prescription, the patient did live close to the pharmacy. Now, the prescription is for Imovane 7.5 milligrams QHS PRN for 30 tablets. So very similar to the last one we had. However, because we actually had this patient's history, because they were a regular patient of ours, we actually saw that this patient was getting this for the first time. In that case, it's not an appropriate quantity and a non-appropriate dose. We always want to start with the lowest dosage possible. For this patient, we actually ended up switching her to Seroquel 25 milligrams QHS PRN, since she was already taking Seroquel XR 150 HS. So very easy switch for this patient. So here are a few communication tips. First, don't lecture. To them, you're a pharmacist who's always going to do things by the book. You've never been in their shoes, and you don't know what they've been through. Overcoming an opioid dependency is one of the hardest things you can do as a human being, and many of us will never accomplish something that difficult. So until you've built that patient relationship with them, don't lecture them, otherwise you're going to have a harder time making that connection. Secondly, don't portray the things you have to do as decisions. Everything you do is actually really the only option given the situation. It's all input to output. So never say, I'm not doing this. Say that since we're getting this message, this is what we need to do. Also, be optimistic that everything will work out until you get that no from the doctor. So tell them, no problem, we'll just fax the doctor and get that interval fixed. Don't be perceived as a barrier between the patient and the physician. I also have here, put yourself in their shoes. And what I actually mean is, I don't mean feel empathy for them. What I actually mean is, if a patient is reacting poorly to something that you have to do, you have to ask yourself, does that reaction fit in practically with their history of opioid use? For example, when a patient taking methadone gets an emergency room prescription for Tylenol 3, that patient who's been using opioids for a long period of time shouldn't be surprised that you have to confirm with the emergency department that the physician is aware that this patient is taking methadone. That patient should have been upfront from the first place and notified the emergency room prescriber that they cannot take opioids because they are on methadone. Pretty much every patient taking an opioid chronically will know the names of all the common chronic opioids and should always make the prescriber aware of what they're currently taking. They all know that they shouldn't be seeing multiple physicians as well, or pharmacies for opioids, and if they're coming to you for the first time and picking up a monthly supply of opioids, then they shouldn't be surprised that you have to verify with the prescriber. So a patient that is excessively upset about any of these scenarios could be overreacting to push you to release that medication. Finally, I have here, put a sign up that says narcotic prescriptions need to be verified. It's similar to some of the signs that walking physicians will put up as well. And that just helps you a little bit in terms of setting the right environment for these interventions to happen. So what else can you do? Well, if they're getting their opioid prescription for the first time, then counsel it as if it is morphine. And mention the word morphine. You can say that it's a type of morphine, especially for things such as Hycoden cough syrup, codeine, or oxycodone products. Patients may not fully appreciate the risk involved with these medications, but they will understand what morphine is. And all of these products essentially work the same way. If they're a chronic opioid user, it is a little bit more difficult to get them to change their habits. You have to build a relationship with them, treat them like any other patient, teach them that higher doses are not more effective, and don't take things personally when things don't go well, and don't let your guard down. But it is not a quick and easy road to help them through. So the last point I want to make is about reputation. If you accidentally fill a forgery, you are more likely to get forgeries in the future. And if you find that you are filling a lot of opioid prescriptions, it could be that your pharmacy has gained a reputation for being easygoing with opioids. The same thing happens with physicians. If a doctor is lenient, they will soon find more and more patients seeking opioids for their back pain or chronic injuries from years past. This is going to cause problems down the line for you because you're going to be more likely to be audited due to the increased number of NMS alerts. So make sure that you have documentation, including signed faxes by prescribers, to show that they're aware of these previous prescriptions and that you have documented properly for these NMS alerts. So that's it for this video. Thank you for listening to me share with you how I handle these prescriptions, and I hope this sparks some discussion among pharmacists because the rate of life lost due to the opioid crisis is really staggering. And so I do think we need to be more connected, more agile, and more practical in our approach to have an impact. If you have any questions, please email me at michael@medisys.ca. Thank you.